Hello, and welcome to episode 29 of the Cancer Pod. Today, we're talking about vitamin D. We're going to cover a lot of what you may already know and a few things that may surprise you about this essential nutrient. I'm Dr. Tina Kaiser, and as Leah likes to say, I'm the sciencey one.
And I'm Dr. Leah Sherman, and I'm the Cancer Insider.
And we're two naturopathic doctors who practice integrative cancer care.
But we're not your doctors.
This is for education, entertainment, and informational purposes only.
Do not apply any of this information without first speaking to your doctor.
The views and opinions expressed on this podcast by the hosts and their guests are solely their own.
Welcome to the Cancer Pod. Hey, Tina.
Hey, Leah. How's the weather?
It's a little overcast here.
Ooh, that's too bad.
You have sun. You're in the land of sun.
I'm in Central Oregon where the sun shines, 330 days a year or something.
Yeah, I'm not jealous at all. So,
well, I will add, it is cold though. It is only probably 30 degrees out there. So it's sunny and cold.
But I'm good with that. As long as there's sun, I'm happy.
I have to say it is kind of nice.
Yeah. When I lived in New Mexico, we had sunny, snowy days, and it was just, so nice. So we're talking about the sunshine vitamin today, aren't we?
Yes.
I didn't know if we should call this supplements 201 or just stick with 101, but we're back on our series of talking about supplements this pod. And yeah, today we're talking about vitamin D.
I think we should keep it to 101 because we're going to keep it basic. And if we do offer more in-depth lessons, then we can call them higher.
201, 401.
Master's class.
Take the master class in supplements. Okay. So vitamin D, what the heck is it? How do we get it? What's it do for us? And then what's it do for us cancer people?
Yeah. And what makes it a vitamin? Why is it so vital to our health?
Okay. So let's take a quick break and we'll come back.
Sounds good.
So Tina, vitamin D, hormone, vitamin, yes to both?
Yes, I say to both because vitamin D is a fat soluble vitamin. So we do get it in foods and we'll talk about that a little bit. But most vitamins, when we talk about a vitamin, must be gotten from food. Vitamin D can be made by the body and is actually a hormone substance rather than a vitamin. So right there, the word vitamin is a little suspect. That said, we call it a hormone, and it really is a hormone because in the larger sense of what a hormone is, it has hormonal actions in the body on cells. So its structure and its action within cells is actually that of a hormone.
It's vitamin-ish, vitamin-esque.
Vitamin-esque. We definitely need it. You know, when we talk about a lot of vitamins, it's synonymous with cofactors. So all the B vitamins, for example, are cofactors. And that means that they must be present for a reaction to happen, for an enzyme to function properly, but they don't have independent actions on cells. They don't go into the nucleus and bind something. Whereas the vitamin D, which is a hormone, has a direct action in cells all by itself. It is actually not a cofactor per se.
Well, that's why you hear about vitamin D receptors on cells, right?
Exactly. Yes. And that gets complicated quickly because there's vitamin D receptors, there's different types of receptors. And generally, we're talking about a vitamin D receptor that finds another vitamin D receptor and they bind together and form these combinations called dimers. And that goes into the nucleus of a cell, binds the DNA in what's called a steroidal element region. And that is very powerful because you're binding the DNA and you're causing the expression of various genes. And those genes go on to create the proteins that have a specific action.
So you just delved into 201 level. That's okay. We'll leave it in.
All right. Well, there's a little taster of our 201.
Wait till you get to the master's level. Okay. So how do we get it? You mentioned that they're foods. what's cool about it is that our body does make it, as you mentioned, and that it's made, like, all of these different organs play a part in making it.
Yeah. Yeah. So first is sun. I think many people know vitamin D as the sunshine vitamin. And that is because it starts with sunshine on your skin. So the UV, the ultraviolet radiation from the sun, activates an enzyme in the skin, and that creates what we call pre-vitamin D. And then that pre-vitamin D goes through some changes and becomes vitamin D as we know it, which is the substance that we have circulating in our bodies.
Yeah, because the liver, the kidneys, and the gut are all involved in vitamin D. So once again, that's a pretty cool thing.
Yeah, and vitamin D, like so many vitamins, is not one thing. There's variations on it. So there's different under the heading of vitamin D, there's various steps along that pathway. We're going to call it vitamin D for every one of those steps, whether it's going through the kidney or the liver. It's being slightly altered molecularly each place. And vitamin D encompasses all of those compounds. So there's variations on subtypes of vitamin D, we could call them. The technical term is vitamins.
Oh, you've used that term before.
I like it because we oversimplify the biochemistry a lot just to make it palatable, but it's good to know the complexity. It's kind of like when I look up at the stars, I know the Big Dipper and it helps me understand, I know the North Star, I know a few constellations here and there, but I do understand that the complexity of what I'm looking at is much bigger than what I know, but I do like to have a few waypoints.
You're not naming every star that makes up the Big Dipper. You just know as a whole, it's the Big Dipper.
That's all I need to know.
That's a good analogy. Okay. So, vitamin D, starts in our skin. A lot of people, especially cancer patients, cancer survivors, are told to use sunblock, whether it's because they have a history of skin cancer or because the treatments that they're getting cause them to be really sensitive to the sun. And so sunblock actually blocks the rays that make vitamin D, which can prevent people from getting it that way. Other things that can keep our skin from making vitamin D depends on where you live. So up in Oregon, it's a higher latitude. And you would need to be in the sun a lot longer, or like in the winter on a sunny day, you're probably not getting as much vitamin D than if you were down in Arizona or New Mexico or Mexico. The closer you are to the equator, the better your skin will be at making vitamin D.
Yeah. Yeah. And you just have to picture the angle that the sun is hitting you at. So up here, let's just say a latitude of 45 degrees is a lot different than down in San Diego, where I think it's more like, you're at a latitude of 35 down there or something like that. The rays are hitting you more directly, hitting your skin more directly and having a bigger effect rather than glancing off of you.
I remember finding a website at one point that you could enter in where you were located, and it would talk about the comparison of how, how long you would need to be in the sun to get the equivalent. And we're not advocating for people to go out and sunbathe and to, just be reckless in the sun, but just knowing that, where you're located does determine how much vitamin D you're getting from the sun, I think is important.
Yeah. And, the idea of UV exposure being linked to melanomas, for example, is interesting, right? Because we also know vitamin D deficiency is not good. And so it sounds like a catch-22, but I think rather than sun exposure, you have to think in terms of sun damage. Like inflammation in the skin from too much sunshine means that the ultraviolet radiation is causing your skin to be damaged and inflamed. That's a bad thing.
Oh, and can I add a note about full disclosure? I went to tanning beds when I was in my teens, and then also when I moved to Portland because it was so gray and gloomy. And so I started going to tanning beds until I learned about the difference of all the UVA and the UVB rays. And one of the things tanning salons talk about is, we're providing, you get vitamin D from our beds, and you don't, because they kind of tone down the UVB rays.
Oh,
because those are the burning rays.
I did not
And
know
they talk about, these are the UVA, these are the tanning rays, which are the ones that are the skin cancer rays. So it's I don't know.
Mm-hmm. Mm-hmm.
Don't go to a tanning salon if you think that that's why, you're doing it for vitamin D. Not recommended because it's not the same as the sun.
Right. Right.
So that was just an aside. But oh, okay. So other ways of getting it through food.
Mm-hmm.
And most of the food sources, if it's not fortified food, fortified foods would be dairy products mostly.
Mm-hmm.
Orange juice is a big one that's
They're mostly
fortified.
then they're fortified with ergocalciferol, right? They're not fortified with anything that's bioidentical.
Which is vitamin D2,
Mm-hmm.
right? Because they're different forms, as you mentioned. And so the ones that we hear about are vitamin D2 and vitamin D3. And so, yeah, so there are, I think almost all dairy products are fortified. There might be eggs that are fortified. And then what they're doing is they're feeding it to the animals typically.
Oh, okay.
If the animals aren't exposed to the sun, because that's how you're going to get vitamin D is because the cow is out in the sun. But I think they supplement it too. I don't know anything about dairy cows, but I do believe I glanced at something that suggested that they need it. I think because they're just producing so much milk all the time.
Oh, yeah. I
So
don't
they
know.
need it for themselves. I think. I don't know. I'm just going to go with that because it's helping out the cows. Seafood. So freshwater rainbow trout has a fair amount, salmon, herring,
Mm-hmm.
and there's various other seafood as well. So that's the other source. And then for all of you vegans out there, mushrooms really are the only
Mm-hmm.
natural source that's non-fortified.
Right. Right. Yeah. And the fishes I know have vitamin D3. So they're closer to what we would be making ourselves than what comes in the milk.
And they would also have fat.
Bonus, vitamin D and some omega-3 fatty acids.
Yeah.
Mm-hmm.
So we've mentioned kind of, what it is. We talked about how we get it. Who's at risk for deficiency?
Yeah. I mean, as soon as you say sunshine, anyone who's not getting sunshine is more likely to be deficient, right? So anyone who's just either covering up or avoiding or at such a high latitude, they just don't get much, right? So there's parts of the world where they have no sunshine for seasons or very little, I should say.
Interestingly, there were a lot of people when I lived in Arizona, a lot of patients who were vitamin D deficient because it's so hot and the sun is so intense.
Mm-hmm.
People weren't going in the sun
Mm-hmm.
or they would just slather on the sunblock. And so they would be deficient
Mm-hmm.
because we would test most of the patients, if not all, most of them.
Yeah. Yeah. So we should say that we routinely test, and we'll get to the lab testing too, but you and I routinely test our patients for this.
So who's at risk for deficiency? The darker your complexion,
Mm-hmm.
the greater risk you are for having vitamin D deficiency. So that is a risk factor. As we age,
Mm-hmm.
malabsorption.
At least for the vitamin D that comes in the diet, right? You're not going to absorb it as well.
Right.
Okay.
Yeah. So for anything that you take in, as a supplement or through food, malabsorption, bariatric surgery, or any sort of condition or surgery that might impair those organs that we mentioned, the liver, the small intestine, the kidneys,
Mm-hmm.
anything that impairs the pathway to make vitamin D. And I'll find a picture.
If you include all the organs that either make or process vitamin D into an active form, I mean, it's a lot of organs.
Yeah. So if you got anything going on with any of those, it may possibly impair. And then obesity is the other potential risk factor.
Yeah. So in all of those scenarios, when they look at populations, you can see that population wide, as the BMI goes up and the obesity is set at 30 kilograms per meter squared for BMI. And BMI is simply an equation that uses your weight and your height and comes out with a number.
And it's pretty controversial.
It's very controversial because it doesn't talk about composition. So it doesn't matter if you're, as far as the BMI is concerned, it will look the same whether you're made of fat or muscle.
Right.
So that is very controversial, but that is where the cutoff is. And it does look like when people are obese, and certainly when they're morbidly obese, when the BMI is up over 35, over 40, there are much lower levels of vitamin D circulating. So generally speaking, in population studies, when they look across the BMIs, people who are obese are much more likely to need to take vitamin D in a supplemental form to have normal levels.
Okay, so we're going to take a break and then we're going to talk about what is a normal level and more.
All right. See you on the other side.
Vitamin D is a fat-soluble vitamin, and it's better absorbed when taken with fat. But how much exactly? One study found a moderate amount of fat, about 11 grams, helped with absorption. That's less than a tablespoon of butter or olive oil, and less than an ounce of almonds. So next time you take your D, take it with a snack. Okay, before we keep going, I want to kind of review what was covered in our previous episode of Supplements 101, which was the basics episode. And what we talked about then was, like the use of a vitamin, like what is the appropriate use of a vitamin? And the first one was to prevent or treat an acute nutrient deficiency. The second reason was to prevent, delay, or treat a chronic nutrient deficiency. And then the third use of a vitamin is for green pharmacy. And so I'll kind of cover some of that, or we'll cover this for vitamin D.
Yes. So as a supplement.
As a supplement, yes. So the acute nutrient deficiency associated with vitamin D is rickets.
Right.
And interestingly, how they kind of discovered that vitamin D could help with rickets, which is like the malformation of bones and teeth, was that children in more temperate, sunny climates didn't have this condition as much as kids in more industrialized countries, in more northern climates. And the children were being treated with cod liver oil and sunshine.
That was their therapy.
That was the therapy, but they didn't know that cod liver oil had this substance in it, which was vitamin D. Like no one had discovered the vitamin yet. So that's the treatment for rickets.
It's always fascinating to me because there's a lot of traditional remedies that predate the chemistry. So that's another one, because we talked about vitamin B12 before, you and I, and it being used for anemia of pregnancy without knowing that they were, using B12. So it's another story where the use of the cod liver oil as a medicine predates our knowledge of why it was working.
Yeah, no, it's pretty cool. And in terms of the chronic nutrient deficiencies, preventing, delaying, or treating using vitamin D, it would be like osteoporosis, fractures. There is association with the level of vitamin D and type 1 diabetes. There's information about multiple sclerosis. I think cardiovascular disease might be another one. So that would be, another reason why someone would take vitamin D. And I couldn't really think of anything that was green pharmacy.
Oh, ultra high doses of it as a therapeutic, you mean?
Or just targeting something specifically. Yeah. Calcitriol, I think, is what we had talked about, where there are some studies that use calcitriol. It's the active form of vitamin D. And that's been used in clinical trials along with chemotherapies. The one that I've heard the most about is with patients with pancreatic cancer. Calcitriol was used along with gemcitabine, which is a chemotherapy that is like a first line treatment.
Right.
And it was supposed to help with, I think, the efficacy.
Did we get results from that one?
I think there were good results. And I had a medical oncologist that I worked with, and that's what he would prescribe for his patients.
Okay.
So that's how I learned of it. And then I found the study and there were positive results, or else the med onc wouldn't have done it.
Yeah.
I think they've also are looking or have looked at breast cancer and prostate cancer as well, which prostate cancer is interesting.
Yes. There was a study for patients with prostate cancer up at OHSU, which is Oregon Health Sciences University. I want to say the PI on that was Dr. Beer. I believe they found that the calcitriol, the 125 dihydroxy.
Is that how you say calcitriol? Calcitriol? I don't know.
I don't know. It could be tomato.
Okay. Well, we'll go with tomato.
But what they use, calcitriol, is 125 dihydroxy cholecalciferol. So that is the one that targets the tissue and actually has the action within cells. And that's also the drug. And it's given in what looks like very small doses, but, potent doses. But nonetheless, it has been used in pharmacological doses. So beyond what our physiology would ever make in some studies. And I know prostate cancer was one of those. But they found out it didn't do anything either way. It didn't help, didn't hurt. So not worth the risk in that scenario.
But that was the only thing where I could find, it being used kind of in place of or along with medications.
There are Can I interject?
Yes.
There is a lot of research in trying to discover analogs of vitamin D that have the benefits of vitamin D without some of the risks of taking a vitamin D supplement. So we haven't really talked about the risk, but of course, vitamin D has a lot to do with calcium homeostasis in the body. And
which is like, that's balancing. Homeostasis is a 2-in-1 word. So we're going to go the balance.
Yes. Making sure your calcium levels are not too high or too low. And vitamin D is intimately linked to that, which is why all the bone issues and teeth issues. That said, a high dose of vitamin D generally isn't used because high calcium can result. And so to avoid that, drug companies are trying to find all the good with no risk and creating these vitamin D compounds, which we call analogs.
And we're going to get into safety and interactions in a sec. But what I said before the break was that we were going to talk about ideal levels.
Mm-hmm.
I guess we should start with what's considered deficient before we talk about an ideal level.
Yeah.
Because there's so much controversy. I mean, I've talked to patients and they're like, I was told my level should be at least 100,
Mm-hmm.
And then someone else will be like, well, I was told it was in normal range. And then when I look at it, I'm like, well, that's still pretty low. So let's talk about what's considered a deficiency. And from my understanding, deficiency is 20 nanograms per milliliter and less.
I think that is, nobody will argue that. If we want to say there's one spot on the scale where nobody will argue that it is deficiency is less than 20.
Right. True. Then there's the wiggle room between 20 and 30, where in my mind, if somebody has less than 30, they're deficient. So if someone came in with a level of 28 and they're like, oh, my doctor told me I was in a normal range, I'd be like, let's kick it up a notch.
Yeah, I'm with you on that. And it's interesting because I was just pulling up the NIH levels in front of me, and that 20 cutoff is where they put it, right? So I'm saying, like, no matter who you are or how conservative, 20 is, everybody agrees on. Most labs will tell you normal starts at 30 or 32. And when we use these numbers, we're talking about nanograms per milliliter, because I should point that out, because in the United States, we use nanograms per milliliter. Most countries in the world use nanomoles per liter. But because you and I are familiar with nanograms per milliliter, let's just stick to one set of numbers. But I'm with you. I think that anything under 30 certainly is insufficient.
Well, when I was working in Oregon, 20 was the cutoff. And then when I moved to Arizona, 30 was. And so from my understanding, lab values are based on the healthy population that goes to the lab. So if you're in a sunny climate, your low levels are going to be higher than if you're in a cloudy area.
Yeah. So yeah, you're right. And so what is ideal? I personally think the sweet spot is somewhere around 50, give or take. So let's just say 40 to 60. So right kind of in the middle there.
Yeah, I kind of go with 40 to 60, except in the case of people who are taking aromatase inhibitors and have that joint pain.
Mm-hmm.
There was a study that showed, they looked at women who were having pains from letrozole,
Mm-hmm.
which is an aromatase inhibitor. And if they had levels greater than 66 nanograms per milliliter, they reported less joint pain associated with their medication.
Yeah, and it is one of the things we haven't mentioned, and that is vitamin D appears to be anti-inflammatory. So that study was done for joint pain in women taking an aromatase inhibitor. But I would say, in general, you want it to be on the upper end of normal, which is 60, give or take, 60 something. If you have kind of a systemic inflammatory condition, so even osteoarthritis or eczema, or, like whatever your manifestation of a systemic inflammatory condition is, you definitely want to make sure your vitamin D levels are adequate at the very least, and maybe even high normal, still within the normal range though. There's no condition or no scenario where I think it should be outside the normal range of the lab. So my labs nearby here go up to 80 as the maximum on their 80 nanograms per milliliter. Certainly above that, I say lay off it, don't take it. Let's get you back in the normal range, because there are true risks of going too high.
And especially as we'll discuss, especially with patients who are going through cancer treatment.
Mm-hmm.
Okay, so again, let's just kind of take a quick break, and we'll be back talking about what to look for in a lab and all kinds of stuff. Vitamin D and cancer.
Ooh, okay. Let's do that. Did you know that the vitamin D circulating in your bloodstream goes into the cells lining your small intestine, and there it facilitates transport of calcium from your gut into your bloodstream?
Okay, so we talked about what the deficiency kind of cutoff is, and the kind of the safe range that your lab should be. But what are the labs that are ordered?
Oh, yeah. So we have to be specific about this because you can order a few different ways. So the levels we're talking about when we were talking about these numbers is the serum 25 hydroxy vitamin D. So this is kind of the circulating amount. This is before it goes to the kidneys and gets truly activated. And this is the way it mostly is circulating in the blood.
But there are times when a doctor may order the other labs as well, looking at your other types of vitamin D.
Yeah, they can order the active form, which is 125 dihydroxy vitamin D. And if you're taking calcitriol, if you're taking the active 125 dihydroxy vitamin D, then the labs will be ordered to make sure that you're not being overdosed sometimes.
I think when people have like kidney issues, they order.
That would
maybe
make sense to make sure that they're activating it.
Yeah. I mean, I've seen it ordered. I ordered it once myself, but I think it's because I clicked it wrong. When ordering the lab, I misclicked it. But moving on. Vitamin D and cancer. So that's kind of the hot topic. One study comes out and talks about the benefit of taking vitamin D. And then another study says there's absolutely no benefit in patients taking vitamin D. So, Tina, which is it?
Well, one of the first things you have to think about when you're looking at studies for any vitamin or nutrient for that matter is what is the study population they're looking at. If vitamin D is given to a population across the board without knowing whether they're deficient or not, that's one type of study, and that is done. It's kind of not a great use of a study design because giving vitamin D across the board, if there's no deficiency, it's likely not to have an effect because people already have plenty of it. When vitamin D is given to people who are deficient, you're more likely to see effects of the vitamin D. So sometimes when you're only reading the headline, you're getting a little blurb in your social media feed or your email, sometimes those are not well-designed studies and they're giving a nutrient, vitamin D or some other nutrient, to a population that is not proven to be deficient. One wouldn't expect that to have any effect unless you're using it in a pharmacological dose and trying to do a drug effect with it. But other than that, most of the studies are confusing because the study designs are either in deficient people or they're both deficient and some of the population is replete. So yeah, we're going to get different results.
And so how much vitamin D needs to be taken to bring someone's level up? I know that the Institute for Medicine and, NIH and, certain places recommend a lot lower levels than what you and I would probably recommend.
Mm-hmm. Yeah. Yeah. So the dietary allowances from the NIH's perspective is somewhere between 400 and 800 IU. And we were getting away from that IU. IU stands for international units. They're moving more towards micrograms, both on the labels of supplements and in their recommendations. So 400 IU is 10 micrograms. 800 IU is 20 micrograms. And this depends on age. So that's from birth to over 70 years old. So it's going to be in that range though, 400 to 800 IU. That said, when you put vitamin D in your mouth as a supplement, for example, and you're not getting it from sunshine and you want to supplement it, some of what you need depends on how quickly you're using it and how well you absorb what you just put in your mouth. So ultimately, the only way to really know how much to take is to do a lab value and take more or less accordingly. That's really ultimately what I do with everybody is if I had to say across the board, a safe dose for absolutely everyone who has normal calcium on their labs, I would say 1,000 to 2,000 IU per day.
Yeah. And I think the Linus Pauling Institute recommends for reducing fracture rate is like 800 to 1,000 IUs a day, reducing falls and fractures in older adults. I think that's the recommendation. I know that, sometimes you have a patient coming to you. I know I have who comes in taking 50,000 international units once a week. And that's prescribed by a doctor typically when someone is found to be deficient. And so that, what does that come down to? That's like a little over 7,000 a day.
Yeah, I've never been a huge fan of that. There have been studies showing that giving large doses infrequently actually led to more fractures when they gave it, when it was vitamin D3 specifically. What you're talking about, the prescription, is vitamin D2,
Right.
ergocalciferol. I'm always a fan of getting a little closer to how it occurs in the body or in nature if you're eating it from fish. So vitamin D3 in a small amount. I'll tell you, I rarely give the capsules unless people really need that convenience, because in my population, again, after giving it, I tested on labs. I would say over half of my patients were still deficient. So I would say almost always I recommend it as something that can be absorbed in the mouth. I don't care if it's a sublingual drop, if it's a spray, however they want to take it, but going in the mouth, it can go across the mucosal barrier of the cheek and gums, and you can absorb it right into the bloodstream. And that way you don't have to worry about malabsorption in that person. And generally, you take a little bit lesser dose. Like if I'm doing that, I would think 800 to 1,000 and then still retest. And if they need more, I can give more.
Yeah, my concern with the drops is to make sure that the drop is the dose and not the dropper, because I have had patients mix that up. And I think that does happen. And so, you want to make sure someone's not taking one dropper full when it's supposed to be 1 to 2 drops,
Yeah. Yeah, I would say some of the sprays are actually better because a pump is a pump. I mean, there's no,
right.
You can see it, you can feel it. A pump is actually probably easier to titrate the dose more precisely than drops. Because the other thing is when you have a dropper and you have it up there, you can't tell if you just put 1 drop in or 2. It's not like it's a...
Right. It's not like you can really always feel the drop going in.
And there was one study that pulled a bunch of these off the shelf and found that the variability was pretty large. So you have to go with a good, reputable company. Don't just buy, vitamin D drops from some company you don't know the quality of. It's really important to make sure it's a good, high quality company that is not going to overdose you unwittingly. That was an actual study. It was published. We can link to it.
Oh, yeah. You have to send me those links so I can put them in the show notes. So, yeah, I think I typically, depending on the season and, where you live, that kind of like, and the patient's level, I look at all of those before determining how much that they can take. I do like a daily dose. So I remember one patient who was taking the 50,000 IU of vitamin D2. And they told me that when they took it, they felt really good. And then by the end of the week, before they took their next dose, they kind of started feeling down again. Their level was super, super low. It was well below 20. And so I recommended that they take, I don't remember what it was, but, to take a higher dose every day and to take it around noon to kind of mimic that high sun exposure time. But I thought it was fascinating how they actually felt better after taking a high dose. And then that effect kind of, waned as they got further away from the dose. And as we mentioned before, vitamin D is fat soluble. So it isn't something like vitamin C, which you just kind of pee out. It does hang out in your body a little bit longer. So there is an increased risk for toxicity because of that.
Yeah. And its toxicity, at least acutely, because it has so much to do with calcium balance. That's truly the danger. If calcium goes too high in the bloodstream, it can throw off the heartbeat and arrhythmias can result. And so this is a very serious and even fatal side effect if someone took a hypertoxic dose of it.
And there are some medications that it can interact with. And I think it's more those that also affect calcium. It's probably also anything that affects absorption.
I do believe that when people are on steroids long term, when they're on an oral steroid long term, that can interfere with absorption of vitamin D in the gut. So if someone's taking, I'm thinking of like my multiple myeloma patients, they're, taking steroids long term, months, years at a time, that certainly can add up. And you have to make sure that if you're taking a steroid, intermittently or chronically taking a steroid, have your vitamin D levels checked. And again, it might be another reason I go straight to the mouth absorption is there's so many scenarios I can think of that could interfere with the absorption of vitamin D. And I had early on noticed that giving it orally often didn't bump the labs up. And so when I went to the mouth absorbed types, no matter what form, it was much more reliable.
Yeah. And, when there are certain conditions like multiple myeloma where calcium levels are.
Yeah. They're already at risk.
They're at risk. That's exactly what I was thinking. And I thought that sounds weird. Yes. So when calcium levels are already at risk, it's really important to make sure you know your vitamin D level and not to take too much.
Right. Right.
Because many patients come to us and they're taking 10,000 IU a day because someone told them to. And I admit in my past, I may have done that before I worked in oncology. And so, if somebody has cancer where your calcium levels can kind of go haywire at any moment, just be really careful about how much vitamin D you're taking.
Yeah. Yeah. And there's a lot of cancers where that can happen. Multiple myeloma comes to mind. There are some lung cancers that can develop what's called a paraneoplastic syndrome, which can cause this. And that paraneoplastic syndrome reminds me that parathyroid hormone also is intimately linked with this entire story of calcium and vitamin D. So parathyroid, whether someone's had one removed, whether someone has a hyperactive one, like there's so much going on with vitamin D that's complicated quickly that the only way to really take it and take it safely is to look at your own lab values to have peace of mind that you're not doing any harm.
So offline, you had mentioned about, I believe it was an epidemiologic study looking at vitamin D in colorectal cancer.
Yeah. It was the brothers, Garland and Garland.
Cedric Garland was one of them.
Yeah.
Right?
Cedric Garland, who's down in San Diego himself now. His entire career has been around vitamin D, but it's kind of a big paper that came out in 1980. And he and his brother, epidemiologists, looked at colorectal cancer mortality and sun exposure. And they found across the United States, when you looked at that you could see that there was at least some kind of trend where in sunnier climates, there was less colorectal cancer mortality than there were in northern climates. And that was kind of the first tip off. His entire career, again, has been dedicated to vitamin D. So I love that he lives, in sunny San Diego. But in a paper that he sent it actually to Congress and made recommendations about vitamin D repletion across the nation and how many breast cancers and colorectal cancers in particular that would prevent. So if we could just keep everybody from being deficient, we could probably prevent a lot of various cancers. He had this huge paper, came out, I want to say 2009. I could be wrong, but we'll link to that paper too. But it was basically a plea to Congress. And in there, he said how many hundreds of thousands of people over time could be spared a cancer diagnosis if we could just keep their range up. And he's recommending somewhere in the range of what I was mentioning, which is, 50, 60 nanograms per milliliter. That's his recommendation.
And I do remember another one of the medical oncologists I worked with made sure that his patients with colorectal cancer were taking at least 4,000 units a day. Mm-hmm. And so I'm sure that's based on some study, which I should look for. Again, we're not recommending that this is what people should take. We're just talking about what has been looked at.
There was one study that came out a couple years ago, and it was interesting in that they looked at women with stage 3 breast cancer. And they looked at them over time and they watched. So people who started out vitamin D deficient, some of them were given vitamin D as a supplement. The people who got their vitamin D into the normal range for that study had better outcomes than those who remained deficient throughout the study period. So when they were watched over time, basically the women whose vitamin D was corrected from deficient to normal had better outcomes. And what I mean by that is the women who with stage 3 who went from deficient to replete in vitamin D had less recurrence than those who remained deficient. That's one of the best studies to show that vitamin D repletion is worth your time and effort.
But for those women who were already in the normal range, there was no difference, right?
No difference.
And I think that's the thing that we need to, kind of keep saying is that if somebody is already in the normal range, there isn't really no need to go higher.
Right. This is one of those classic scenarios where more is not always better. And certainly, like I said, I'm going to reiterate that if it's outside the normal range, you need to bring it back down into it because you're definitely pushing your risk benefit beyond limits. You're definitely taking more risk than you are deriving benefit over the 80 nanograms per milliliter mark.
And then there was something that saw an inverse correlation between vitamin D and prostate cancer.
That outlier. Yes, prostate cancer. So prostate cancer, breast cancer, and colorectal cancer, and even some lung cancers are all adenocarcinomas. So this type of glandular tissue, adenocarcinomas. So you'd think they'd all behave similarly. They don't. So prostate
Damn
cancer,
them.
I know. Just when you think you can make some generalizations based on a tissue type or something. No, prostate cancer, I have always said, is its own kind of subset. You have to look at prostate cancer completely separately than you do. Breast and colorectal cancer have a lot more in common than prostate with either one of them. It may have to do with the specialized cells of the prostate and how the whole metabolism of energy is different in the prostate cells. In any case, all bets are off with prostate cancer. There does seem to be some inverse correlation where lower vitamin D levels were associated with better outcomes. And they weren't giving it as a supplement. There was nothing like that. It was just looking at populations and looking at men with prostate cancer, how they fared over time. And the men with the lower levels fared better. The analysis of that information, by the way, has a lot to do with testosterone levels as well. And so it gets complicated again very quickly because we're talking about two hormones now. Whether testosterone was normal or low may have had some effect on those results. But regardless, just looking across the board, it did look like taking a lot of vitamin D was not beneficial for men with prostate cancer.
It's so complicated.
Yeah, it's because cancer is not a monolithic thing, right? Cancer is every organ, and even within that organ, there's subtypes of cancer. So it's not one thing. When we say cancer, it's almost just describing how the tissue behaves rather than what the tissue is.
Right.
So yes, it is complicated quickly. That's why entire careers are dedicated to just one.
All right, Tina, anything else that we want to add?
I don't think so.
Besides the song?
Well, the song's kind of a given when we're talking about sunshine. So.
I know. And you actually came up with this song, which, our unofficial theme song for the episode.
We can thank John Denver.
You going to sing?
Oh, God, no. I can't put people through that. It's just not nice.
Well, it's a song from my childhood. Sunshine on My Shoulder.
Mm-hmm.
That's what it's called, right?
I don't know.
That's how I know it.
Sure. Yeah.
That's how I know it.
We'll call it that. I think everyone knows that.
Well, everyone of a certain
age.
Of a certain age. Sunshine on My Shoulders. I just did the Google by John Denver. That is our song. I didn't do previous research on it. So, apparently it was the B-side.
See, you learned something new.
Wow. And that's the song that I know, not the other one. But anyways, that came out in 1971. It's a folk song. If you don't know it, you can find the link in our show notes and on our website. I'll post a link to the video, which on YouTube has received over 11 million views.
No wonder I know it.
That's how you know it. So I think we kind of covered a lot. I know we covered a lot. And if you aren't already, remember to subscribe, rate and review. Tell us what you think of us.
And check out our website, thecancerpod.com, because we have a few more blog pieces on there, some information, some recipes that you might like.
And you can always buy us a coffee. We do this ourselves. We do have help with some of our episodes. And so every coffee that is bought for us helps us to focus more on our content and less on all this production stuff.
Yeah. And we want to do more in-depth lessons because I want to go off on all this biochemistry and, make this into a massive lesson, but I am holding back the 201s, the 401s, and the master's class. And I need to do that. We need to get out there.
I know. And we've got ideas. We just need to get our act together. Yeah. Check out our website, thecancerpod.com. We're on Instagram, Facebook, all kinds of places. We're always the Cancer Pod.
Yeah. And send it to a friend.
Send us. Yes. If you like what you hear, pass it on. Share with someone you love.
Mm-hmm.
And on that note, I'm Dr. Leah Sherman.
And I'm Dr. Tina Kaiser.
And this is the Cancer Pod.
Until next time.
Thanks for listening to the Cancer Pod. Remember to subscribe, review, and rate us wherever you get your podcasts. Follow us on social media for updates. And as always, this is not medical advice. These are our opinions. Talk to your doctor before changing anything related to your treatment plan. The Cancer Pod is hosted by me, Dr. Leah Sherman, and by Dr. Tina Kaiser. Music is by Kevin MacLeod. See you next time.
All right. So I think we did cover a lot. We kind of covered what vitamin D does. Like, did we talk about bones?